This is Neurovascular Imaging number 9, prepared by Prof. Sharaf and revised by Prof. Ram Edward. Talk about some venous anomalies. Vein of Galen AVM. It's a complex vascular anomaly that consists of either parenchymal AVM and varix of the vein of Galen, and this carries high risk of hemorrhage or primary malformation in development of the vein of Galen as an AV shunt, and this caused heart failure and hydrocephalus. So it is either a complex anomaly with hemorrhage or a primary malformation in the development resulting in AV shunt. This is the appearance of calcific aneurysm of the vein of Galen with hemorrhages, large aneurysmal dilatation of the vein of Galen surrounded with edema and obstructive changes. The T1 weighted images shows hemorrhages, large vein of Galen aneurysm with congestive heart failure and hydrocephalus. Of course, the draining also are dilated. The drained are dilated. Veno-occlusive disease involving any of the following: either venous sinuses, cortical veins, deep cerebral veins, internal cerebral, Rosenthal, or vein of Galen. So either venous sinuses or cortical veins or deep cerebral veins. Venous sinus thrombosis complications is secondary infarction and hemorrhage. Causes: the use of contraceptives, pregnancy, puerperium, dehydration, especially in children, infection like mastocytitis, otitis, meningitis, tumors with dural invasion, hypercoagulable state, blood dyscrasias and coagulopathies. All these can result in sinus thrombosis. Findings: a clot in the sinus, which is seen as hyperdensity in the non-contrast CT, and hypodense negative shadow on contrast enhanced CT scan. Dural enhancement of the sinus margin, that is delta sign, with negative intraluminal shadowing. On MRI, we can have bright sinus in T1 and T2 denoting hemorrhage. This depends on age, whether it appears as subacute, late or early, and the absence of flow void in any of the following: spherosagittal sinus, transverse sinus, sigmoid sinus, and cavernous sinus. We have secondary effects as subcortical infarcts, and we have corticomedullary hemorrhages. And as we said, risk factors include pregnancy, hypercoagulable states, infections, dehydration, and invasion of tumors. Usually in sinus thrombosis there is hemorrhage or a hemorrhagic infarct, besides the signs of thrombosis itself. TD, time of flight, MRV versus MIP, maximum intense projection, and the flare in the left transverse sinus thrombosis. This is the left transverse sinus thrombosis, and here nothing seen, here non-filling, here the infarct, the hemorrhagic infarct. hyperdensity in the straight sinus, sinus thrombosis, hyperdensity in the transverse sinuses, sagittal T1, in sagittal T1 there is absent normal flow in the superior sagittal sinus. In axial T2 there is abnormal flow signal in the transverse sinus. And signal abnormalities at the peripheral sign region. MRV shows absence of flow in the dural sinuses, absence of flow in the superior sagittal or the sigmoids or the transverse. So this is an appearance of multiple sinus thrombosis. Straight sinus and vein of Galen thrombosis. This is the region of the straight sinus, and this is the region of vein of Galen with bilateral thalamic infarct. This is the bilateral thalamic infarct. So think of something along the vein of Galen showing T1 hyperintensity and the straight sinus which is not filled. Of course, this could be due to metastatic disease, could be due to encephalitis, could be due to thalamoperforator occlusion, but here it is due to venous sinus thrombosis of the vein of Galen and straight sinus. Now we will talk about intracranial extraaxial hemorrhages. This typical appearance of epidural hemorrhage, typical appearance of associated parenchymal and epidural hemorrhage, search for fractures, subdural hemorrhage. All of these are acute hemorrhages seen as density in the CT, subdural hemorrhage extending into the tentorium edge. And here we have the attenuation, which is different. Here the attenuation is hyper a little, but here it is iso. Then so this is bilateral subdural. One is less than 3 days and one is 3. This one is less than 3 days and this one is more than 3 days. It becomes hypodense. Subacute late, appearing in T1 and T2 as bright, late subacute hemorrhage. Here right cerebral convexity, hypodense and isodense subdural hematoma, partially hypodense, partially isodense. This occurs in anemia, birth injury, coagulopathies. Of course, there is mass effects. This is complex subdural hematoma. Seen as bilateral with layering, lamination, and different age. Some are dark, some are intermediate. Here is the large one, intermediate, subdural. So this is bilateral subdural hematoma. The acute is hypo-intense in T1 and T2, and the subacute is hyper-intense in T1 and T2. In T1 and T2. So what is this? Subacute subdural hematoma. This is chronic subdural hematoma, where we have lamination and layering, and more than one density is seen, with septa formation. So lamination, septal formation, and layering are all signs of chronic subdural hematoma. Layering, chronic subdural hematoma. Now, what is this? This is bilateral. This is something maybe different from what I was talking about, but it is important to know about it. That is the deep white matter ischemia characteristic appearance. If it is in a young, this is leukodystrophy, but if it is in the old, it is a small vessel disease. So don't forget that. Leukodystrophy and small vessel disease according to age. Thank you.